This is the child with GU dysfunction part 2, where we're really just going to focus on glomerular disease. The two things we're going to look at are nephrotic syndrome as well as acute glomerulonephritis, and both of these actually you probably have discussed in adults, but we're going to give it a little bit of the pediatric twist. So when we talk about nephrotic syndrome, we still are not quite sure what causes it. We know that there's an increased glomerular permeability to plasma protein that causes massive urinary protein losses. So these kids present with massive proteinuria or hyperalbuminuria, hypoalbuminemia, hyperlipidemia, of which they have no idea why, edema, ascites, and hypovolemia. So they become these huge puffballs. And I would tell you they are so uncomfortable. Their skin gets taut. They feel lousy. They just really are quite symptomatic. And you do see these kids hospitalized for aggressive management. There are several different etiologies to this, but the most common that we see in children is minimal change nephrotic syndrome, which occurs in about 80% of children. So the onset of this is between about 2 and 7. We still don't understand why it happens. All we know is that there's some sort of disturbance that happens in the basement membrane where the glomeruli become more permeable to protein, and consequently there's a flow against the way that it normally should go. There's an immune-mediated disturbance, physiochemical, biochemical, metabolic. There are a lot of things that are happening, but all in all, it causes an increased leakage of protein and loss of protein. So the clinical manifestations of these, as I said, these kids become very, very puffy. They have weight gain, they have facial edema, they have pedal edema, they have ascites and abdominal edema. They can end up with pleural effusions in the lung. They have their intestinal mucosa becomes thick and edematous, so they don't want to eat, they don't eat well, they don't tolerate their feedings well, they have intestinal absorption problems, they can become lethargic, they're easily fatigued. Most kids have a normal to a slightly low blood pressure, and obviously, one of the classic things in this that you can look for are urine changes. So these kids become their urine output decreases, and when they do void, their urine is very frothy. The diagnosis is really made suspected based on unexplained weight gain over a short period of time and increasing edema. The hallmark symptom is massive proteinuria. Usually if you dipstick it or you do a UA, you get +3 or greater. Hypoalbuminemia, which is decreased albumin or protein in the blood. Hypercholesterolemia, so you'll see that in the blood. We can see hemoconcentration with a normal or slightly elevated H&H. The platelet count may be elevated, the sodium may be low, but the three classic signs really are that massive proteinuria, hypoalbuminemia, and hypercholesterolemia. So how do we treat it? How do we manage it, and what's its prognosis? So if we look at management, corticosteroids are the first-line drug. It usually is a fairly long course. It's 4 to 8 weeks. Remember, when we talk about corticosteroids in children, we have to think about growth problems. So we do not use them liberally. We know that it can impede growth over long periods of time. And remember, with steroids, when we give them, we shut off your natural production of steroids. So you have to not only give the doses, but then as you wean someone, you have to taper those doses over a period of time. So they give those higher doses, they look for the response, and then they taper them gradually over a period of time. There may or may not be some dietary restrictions, low salts, low fluids. If it's really severe, we do give some diuretics. Sometimes we give albumin chased with Lasix in order to try and pull that fluid out. We use antibiotics to treat any infection, and if we can't figure out why this is happening or if it becomes recurrent, we may indeed do a renal biopsy to see if we can differentiate the type of nephrotic syndrome. Generally, this is fairly self-limiting once we get the treatments on board. However, these kids, about 2/3 will relapse. So it's really important that not only is the treatment regimen really followed, but that they monitor for relapse. So some of these kids will go home with urine dipsticks. The parents will monitor so that they can get early intervention should it occur again. If they do not respond to frequent if they continue to have frequent relapses and don't respond to treatment, they actually can sometimes go to more aggressive drug therapies like cyclosporin or immunosuppressant medications. As I said, when we talk about the long-term and short-term side effects of steroids, we really have to think about what happens with children. So, and when we talk about steroids, we're not talking about these kind of steroids. These are anabolic steroids. So, in the short term, you have weight gain, a rounding of the face, you may have behavior changes. I will tell you, people who take steroids notice that they're a little abrupt, a little curt. Some people may have an increased appetite. But short term isn't as much a problem for children as long term. So we think about people who develop a lot of hair, that's hirsutism. They have restricted growth. It can cause increased blood pressure. It can cause bone demineralization, increased risk for infection and hyperglycemia. So the hyperglycemia and the infection and bone demineralization are obviously things that we think, and hypertensive. We think of those with adults as well, but think about children who are trying to grow and ossify and develop. Bone demineralization is obviously of great concern, just like someone who is older. And growth retardation or growth restriction in a child who's trying to gain height, it can obviously have severe effects. So children on long-term steroids, for whatever reason, need to be closely monitored so that we're sure that we're not impeding other things and there aren't side effects that we're missing. So, when we talk about nursing considerations for children with minimal change nephrotic syndrome, we have to think about the fact, first of all, they're edematous. So we need to monitor strict intake and output. We need to make sure that we are monitoring urine studies, looking at those protein losses, looking at specific gravity, looking at what's happening. We want to get a daily weight, again, to monitor the weight, monitor their fluid status. We need to check in younger children, we may check an abdominal girth, which is measured right across the umbilicus. You may have done that in the Well Baby Nursery. We do that in order to monitor for ascites and abdominal edema, all that third spacing of fluid that happens in the abdomen. Skin care is critical. These kids, their skin will get so tight, they can end up with skin breakdown. We need to make sure they're repositioned adequately because they really are lethargic and don't really want to do much. If they're sitting a little upright, they'll get scrotal and upper thigh and perineal edema, so you need to make sure you're repositioning them so that that edema doesn't pool in any one particular location. We need to monitor vital signs. These kids can end up in shock because they end up intravascularly depleted. Obviously, they have poor appetite. Once they start feeling a little bit better, we need to make sure they get good nutrition, so you may need a dietitian to treat that anorexia, that poor feeding, that edema in the bowel wall. And obviously, when these kids don't feel well, this is not as much of a problem, but providing recreation, diversion, some sort of activity when they start to feel better until they really are able to get up and about is really important as part of their nursing care. So, the other associated disease, things that we see commonly, and these two things are commonly confused, nephrotic syndrome and acute glomerulonephritis. Again, acute glomerulonephritis, we're not quite sure of the pathophysiology. The clinical manifestations, again, that edema, that weight gain. We have oliguria. We have circulatory congestion. These kids, interestingly, in contrast to the nephrotic syndrome children, have hypertension and In addition to proteinuria, they have hematuria. So these kids have nephrotic syndrome. Children have that frothy urine from that protein. These kids usually have tea-colored or blood-tinged urine from the hematuria. So you can differentiate based visually. If you have a kid who comes in edematous, you check the urine. Sometimes just by looking at the urine, you can suspect whether it's acute glomerulonephritis or nephrotic syndrome. Most cases of acute glomerulonephritis are post-infectious, and the most common infection is our friend group A beta hemolytic strep, or acute post-streptococcal glomerulonephritis, or after strep throat that has been inadequately or not treated. And this occurs usually about 10 to 21 days after the initial infection. So again, the diagnosis, we can look at a urinalysis, we can look at it during the acute phase. We have proteinuria similar to that of nephrotic syndrome, but we also have hematuria. And those two things run parallel. As the blood is high, the protein is high, and as the protein goes down, the blood goes down. We have that characteristic blood discoloration, that tea-colored urine, and we can also see things like red blood cells and leukocytes on urinalysis screening. About 50% of kids also have abnormal kidney studies, so you may see an elevated BUN and creatinine. And we always check a serologic study. We look at the ASO or ASLO titer, which is the antostreptolysin titer, which looks for a previous strep infection. So these kids don't have an active strep infection at the time that they develop this, but in order to figure out whether the cause was a prior strep infection, you need to obtain this titer, and that might explain the cause for this. On chest x-ray, again, you can end up with this third spacing of fluid. You can end up with cardiomegaly, pulmonary congestion, fluid in the lungs, as well as pleural effusion from the third spacing of that fluid. And unusually, we would have to do a renal biopsy in order to diagnose this particular problem. Most of these kids, in contrast to nephrotic syndrome, really are managed at home. So as long as they do not have blood pressure problems and have an adequate urine output, they're usually monitored at home and do not require hospitalization. If that edema becomes so severe, if there's severe hematuria, significant oliguria, and increased hypertension that really requires monitoring and treatment, those are the children who will be hospitalized with acute glomerulonephritis. From a management perspective, if there is a positive strep culture, we need to get the kid on antibiotics, or for any other potential infection that may be recognized, we may give diuretics. We need antihypertensives in order to treat these children. These kids may present with headache, unexplained headache, and a blood pressure should always be monitored to see if that's the cause of that. And there are some dietary restrictions, just a moderate, low protein, low K if the kid is oliguric, really just in the severe stages. Most of these kids have an excellent prognosis, and they recover completely, and this uncommonly recurs. This is in contrast to the nephrotic syndrome, which really does recur. Nursing considerations for this, very, very similar for nephrotic syndrome, because when you think about it, you have edematous children, you're monitoring their urine output, you're monitoring the edema, you want to monitor their vital signs, especially that blood pressure, because we know they're at risk for hypertension. We want to monitor a daily weight, we want to look at the character and the volume of the urine, send any appropriate urine studies that may be ordered, monitoring the blood and the protein in that urine. We want to monitor for dehydration. These kids related to edema, they can end up with cerebral complications, they can end up with seizures as well. Remember, we have the edema that's happening within the brain, but we also have the hypertension. So we can have dizziness or disorientation related to blood pressure as well as related to edema. We know that we have the hematuria as well, so that's a concern. These kids really usually are on a regular diet. As I said, sometimes no added salt, maybe a little bit low or no high sodium salt. During that acute phase, you may have some K restriction, and a dietitian involvement is really important. That's it.